everybody. This is another round of video notes on specific categories of mental disorders. Today we're going to take a look at depressive and bipolar related disorders. They were previously referred to as mood disorders, so if you ever hear them categorized in that regard, you'll know now what they're being talked about there. But ultimately, when we make this mention of mood disorders, it's important to recognize that what we're addressing is a category of disorders that deals with disturbances in emotional feelings that are going to be strong enough that they interfere with your everyday daily functioning. Okay, so anyone who has ever struggled with depression, anyone who has bipolar disorder, any of you guys that know people who have had either of those disorders, you know how difficult it is for people to function in everyday society, day in, day out, with what is going on in their minds in those moments. So let's talk what we use as our technical term for depression, which is major depressive disorder. It's often been referenced that depression is what's called the common cold of psychological disorders, in the sense that it is quite prevalent. Between 6 to 10% of the American population is clinically depressed. It's the #1 reason why people end up seeking out treatment or any kind of mental health service. If you look at the circumstances of teens, that percentage is going to go exponentially larger when looking at teens individually as a group. Women are twice as likely as men to develop and experience major depression. It's perceived out there actually that about a quarter of all women will experience an episode of major depression in their lifetime at some point. That's not to say that men do not experience major depressive disorder. There are many within the field that feel that the higher diagnosis of depression in women over men is because ultimately what society tells us regarding genders and expression of emotion. Women are permitted, societally speaking, to be more emotional, and so therefore they're encouraged a little bit more to go seek treatment for these kinds of circumstances. However, men are taught via various different messages from society that you are supposed to be tough, suck things up, men don't cry, things along those lines. So often what you end up seeing in male behavior with those that have major depressive disorder, it presents itself as other issues like drug addiction and attempting to self-medicate in that regard. So when we're talking about major depressive disorder, let's discuss symptoms. This is a very critical differentiation, I think, because an awful lot of people have said before, or kind of nonchalantly, like, oh, well, this life event made me depressed. Well, how do we clinically diagnose you as being truly depressed as opposed to just very sad over a life experience that happened? A person's symptoms have to be prevalent for at least 2 weeks without a cause, or present due to grieving symptoms for 2 months. Okay, so those are two very different components when you're looking at time frame of the disorder being present. It is possible for a person to develop major depressive disorder and there is no cause. They didn't experience some kind of trauma, loss of a loved one, anything like that. To them, it really just felt like they kind of woke up one day and the overwhelming sense of the symptoms that they experienced were present, and they just didn't go away. On the other hand, it is possible to experience a life event that is pretty traumatic, like the death of a loved one or something like that, and then to be experiencing the grieving symptoms that correspond to the loss of that relationship for roughly 2 months. So you could have either of those present. There's got to be either depressed mood or loss of interest in most activities that individual used to find engaging. And then you need at least 4 of the following: marked weight loss, or it's possible for them to be weight gain. There are circumstances of people doing what we call emotional eating to just divert a lot of their pain and their suffering into just eating away the sadness to an extent. Constant sleeping problems. Those with depression, they have what we call ruminatory thoughts. They think and they think and they think and they think over their depressive perspectives, and that makes it really hard for you to be able to fall asleep because you just feel overwhelmed by those thoughts. So then you can't fall asleep, so then you're really tired all the time, and depression in and of itself can make one tired because it's linked to so low serotonin levels, which are connected to mood, appetite, sleep. Highly agitated or greatly slowed down behavior, and that's something that seems very counterintuitive to people. Why would you demonstrate agitation if you're depressed? But an awful lot of that connects with the thought processes. And it's also possible for depression to be diagnosed with another type of disorder. Very common for you to see circumstances, for example, of a person with depression to be diagnosed with a specific anxiety disorder as well. Many of my students, for example, have been diagnosed as both generalized anxiety and having major depressive disorder. There's also an inability to think clearly, again, because the depressive thoughts just don't allow that to happen. A sense of worthlessness, a feeling of hopelessness, that the situation is never going to get better or improve, that there's nothing that you can do to help your situation. And the most unfortunate part of depressive disorder, which is frequent thoughts of death or suicide. One of the big things that people often want to know is what causes depression, especially when you look at that definition of how we would ascribe it from the DSM-5. What is going to cause it? Is it just a life event? Not necessarily, because if you go back to that definition, it can be present in a person for 2 weeks for no known cause in terms of life experience. So then that brings us to kind of a biological predisposition or context to things. And then sometimes it could be any number of combinations. And we'll come into that in a second. So let's talk about the biological cause that we believe to be out there. We connect it to low levels of neurotransmitters in the brain, specifically serotonin, norepinephrine, and dopamine. Well, when we get to treatment, you're going to hear me talk about things, for example, like SSRIs, SNRIs, things along those lines. And so what you want to make sure that you keep in mind for that is that's going to connect back to the specific neurotransmitter that is present there to be causing that person's depression. And this is ultimately why it's so difficult to treat people with depression when it comes to just medication alone. Some people, their depression is caused by low serotonin levels. For others, it's low serotonin and norepinephrine. For others, it's low serotonin, norepinephrine, and dopamine. And in others, it's other combinations of those. So that's why it takes so long for an individual who is depressed, clinically so, to receive a level of balance to their emotional state by medication, because that neurochemistry is just so nuanced in trying to figure out what it is. With social cognitive theory, the argument out there from their perspective for what causes depression is the negative thoughts that ultimately end up influencing the negative behaviors that a person will operate on with depression, like withdrawing from family and friends and perceiving that they don't understand you. And that ultimately ends up influencing your situation. You begin to isolate yourself, so then therefore you feel isolated all the time and that people have stopped caring about you and loving you or things along those lines, and that's what ultimately ends up leading to what's called the depression cycle. So you've got a negative stressful event that leads to kind of those ruminatory, pessimistic thoughts you heard me make reference to earlier, which causes a very hopeless state. The person perceives that their situation just cannot be helped in any way. That ultimately ends up hampering and influencing your ability to look at the situation from a light that it can be helped. And so you end up feeling very rejected and isolated as a result. And so that's just going to keep facilitating and perpetuating the cycle accordingly. It's important to recognize that there are other types of depressive disorders out there in varying degrees to depression. Okay? It is possible for a person to have what we call dysthymia, where you have depression, but ultimately it's a very mild form of it. It's also been referenced as persistent depressive disorder. So it's not major depressive disorder, but it still can explain why a person has the blues, so to speak, on a pretty consistent, continual basis. There's also something called disruptive mood dysregulation disorder, which has been a new thing kind of categorized within the DSM-5. And this is characterized by extreme bouts of irritability, heightened anger, and pretty intense outbursts. This goes beyond, what an individual would have originally seen as like being a moody kid, because that's the thing for many adults. When dealing with teen depression, how do you tell the difference between somebody who is truly struggling with depression or anxiety or other issues and someone who's just got a whole lot of hormones coursing through their system as a teen and they're just being a typical moody child, right? These individuals with DMDD have significant impairment to their ability to function at an everyday level, and so ultimately that's how they could be diagnosed with that disorder. It's also possible for you to have premenstrual dysphoric disorder, which is kind of the more updated version of PMS to an extent. Now, let's move on and let's discuss bipolar disorder, because this is another category that can have subcategories attached to it. You can have bipolar 1, bipolar 2, cyclothymic disorder, for example. So we'll get to all of that. But make note that bipolar disorder used to be referenced as what was called manic depressive disorder. And ultimately, that's because the key defining characteristics of bipolar disorder is that you have swings and bouts from depression and what we call mania. Okay, so the person has this big swing and uptick in their moods in the presence of emotional stability. So let's talk depressive symptoms first, and then we'll hit manic symptoms. Okay, so in terms of the depressive states that they find themselves in, they are highly gloomy, very withdrawn. They cannot make decisions for themselves, and they feel very tired. Kind of feel like they're trudging through mud when attempting to think and process through things. They can struggle an awful lot with a sense that their situation is hopeless and worthless, very similar to those with major depressive disorder. Here's the thing, though. From that point, then, they will swing into a manic episode. Manic episodes are going to be categorized by virtually the complete opposite of what you see in depressive states. So these individuals, when they're in the manic states, are going to be highly euphoric in the sense that they're just going to be, high energy, very hyperactive, desiring for constant levels of action and having multiple ideas on how to solve some of the world's biggest problems, for example. That's a very marked difference from how they would have been in the depressive state, where some of the greatest motivation that they could have given to you was just being able to get out of bed that day. So it's a major movement back and forth when you're dealing with a person who's on the bipolar spectrum. An awful lot of individuals who are pretty well known in terms of being writers, poets, composers, they created some of their most famous works while in manic states, coming up with multiple ideas of how to, create these novels, being able to stay awake for days on end when in their depressive states, they would find themselves struggling to be able to wake up for days on end. Okay, and so then that creativity would drop pretty exponentially when they were in those depressed states. Now, when you look at different types of bipolar disorders, it's important to look at the categorizations and the diagnoses. So bipolar 1 is the experience of full-fledged manic episodes and major depressive episodes. Okay, so that's the full-fledged kind of bipolar tendency. However, it is possible for you to be diagnosed with what we call bipolar 2, which is also referenced as hypomania. They get manic episodes, but to a lesser extent. Okay, so when people have hypomania, they don't see it as a problem, but the people around them could have, some concerns about the level of erratic behaviors that they're demonstrating on. A person has to have at least 4 days of hypomania in order for an individual to be diagnosed with bipolar 2. Then you get cyclothymic disorder, which is lesser degrees of the bipolar tendencies in terms of the swings. Okay, so they can have the hypomanic and depressive symptoms, and they have to be present for at least 2 years, but they don't have to constitute the full-fledged major depressive state or full-fledged manic state. So if you're sitting there thinking to yourself, oh my gosh, this seems just like so nitpicky, to some extent, there are many who would agree with you. This is just simply attempting to, provide understandings of people's behaviors if they're not full-fledged 100%, bipolar in the sense of full manic versus full depressive episode states. Okay, so what are causes of bipolar disorder? Much of it looks to the biological. There's an awful lot of evidence that it is an inherited predisposition, just as it is with depression. We know that there's an awful lot that connects there in terms of genetic predisposition to depression as well. 2/3 of those with bipolar disorder, it runs in families with regard to mood disorders in general. Okay, so there is some kind of history, whether it be depression, major depression, or bipolar tendencies. So that's a pretty high, substantial number that lends an awful lot of credence to a genetic predisposition. That doesn't mean that there aren't some other kinds of factors that can play into this. Stressful events, for example, can trigger manic episodes. And oftentimes it can trigger, swings back into the depressive states as well. So there are definitely biological and psychosocial factors as well. If you take a look at this brain scan to kind of evaluate how it is that the bipolar brain in a bipolar individual swings from state to state in this disorder, look at the level of activity in the brain. And when you look at this, it becomes pretty obvious to you ultimately how they present themselves in the depressive state and why they show those behaviors than when they move and they swing into a manic state, and ultimately how quickly that happens too. When you look at the depressed state in this brain right here on May 17th, the next day they swing into an episode of mania. They go into the manic state. Okay, look at the amount of activity that's present there. I mean, that is a lot going on in that PET scan. But then when they switch back to a depressed state, roughly 9 days later, so a little over a week, about a week and a half, they're back into very low levels of activity, even lower than they were before the manic episode. So obviously, this kind of swing back and forth in these states can lead to some pretty heightened inability to function on a normal everyday level. Here's the thing that an awful lot of students struggle with when presented with this content, though. This sounds an awful lot like borderline personality disorder, these big swings in inability to maintain relationships with people, inability to have decent interpersonal relationships, ability to perceive yourself appropriately, kind of seeming to go from one end of a spectrum to another in terms of your emotions. So what ultimately is the big difference? Well, the big thing to keep in mind here is that people with bipolar disorder, it's due to a chemical imbalance in their brain. Okay, for those with BPD, that's not necessarily the case. That's not to say that there are not biological causes to their development of their personality disorder, but it's not necessarily the same chemical imbalance that is connected to bipolar tendencies. People with BPD also go through their emotions far more quickly. Okay, so we're talking like a cycle between one state of emotion to another several times a day in borderline personality disorder. Whereas with bipolar patients, that it's going to be presented in every couple of days or every few days. So that's definitely something that can be there to help you guys differentiate between those two disorders, since they do tend to sound similar. And it's not out of the ordinary for the two of them to be misdiagnosed as one being the other or vice versa. So that is the end of your major depressive and bipolar related disorder notes. As is always the case, let me know if you have any questions.